Good afternoon, everyone, and welcome to our webinar today. I'm Lynette Biery, Strategic Director of Zero to Thrive in Medicine in the Department of Psychiatry. Zero to Thrive promotes the health and resilience of families from pregnancy through early childhood with research, education, partnership, and service. We're excited to again be working with the Governor's Office and Laura to bring you this panel, COVID-19 and Young Children during flu season. And on our panel today, we have two of our Zero to Thrive Translational Network members. The Zero to Thrive Translational Network is comprised of multidisciplinary faculty from across Michigan Medicine and the U of M campus, who work collaboratively to find solutions to multi-generational problems created by adversity and inequities. It is my privilege today to introduce to you our esteemed panelists. We have with us today Dr. Sharon Swindell, academic general pediatrician and child health advocate. We have Dr. Layla Mohammed, who is an assistant professor in pediatrics at Michigan Medicine. We have Michelle Richard, who is a policy advisor on early childhood to Governor Whitmer. And we have Erika Bigelow, child care licensing area manager. And I will be serving today, as I did on our last webinar, if you were able to join us as the moderator. I want to start our conversation with paying a little attention to prevention, because ideally we could hopefully prevent COVID and flu in young children. So Dr. Swindell, I'm wondering if you might share some of your expertise on just how we might go about to having a prevention framework and approach to all of these difficult symptoms and illnesses that we're facing right now.
Absolutely, and thanks for having me, and I hope that Dr. Mohammed and I can help clarify some of these really hard decisions that people are having to make. I thought I'd start by just setting the stage of where we are with COVID when it comes to children. Lots of times children are not in the news as much as the adults are. And, just wanted to make it clear that this is a real disease that affects children as well. Just looking at the most recent information from about a week ago, over 1 million children in the US have had COVID, and 31,000 in Michigan have. The good news is children represent a very low percentage of people with infections who've been hospitalized or died. But we don't completely understand how they play a role in transmission. And so when we're looking at a pandemic with high community transmission, we have to protect everyone. And so, when we talk about COVID and influenza, and we'll be talking about it quite a bit more during the course of the webinar, prevention is really the key. And most of the efforts for prevention are the same ask that you have been hearing over and over again for the last many months. We will keep saying it from the medical community because these are both respiratory viruses. So wearing masks that cover the nose and mouth is one of the absolute keys to prevent the spread of the virus. Keeping our distance to the degree possible, and we know that's more challenging in a childcare setting, but to the degree possible, and washing hands frequently. We'll keep going back to those things. But to these, I would add several important additions as we go into winter at a time when there is high community transmission of the COVID virus, and when we're trying to prevent other illnesses. Influenza vaccine, I can't emphasize this enough. Influenza vaccine is a tool we have to prevent influenza. And all children 6 months and older and all staff would be highly recommended to be vaccinated if we want to protect the spread of influenza in a childcare setting. And then the other big thing to add to prevention is stay home if there are symptoms of illness. That's the bottom line. And this is not a typical winter. Families are stressed. Families will be inconvenienced by disruption in care, but this is the way we can prevent spread of both influenza and COVID.
Lynette, can I add one piece there too? I know we have our childcare providers on the line today. When Dr. Swindell talked about flu shots, I think it's not always in our lane in the childcare industry to be talking about flu shots, but you are such a trusted voice for the families who are in your care, reminding them that that is a tool that's at our disposal that's really critical this winter. I think absolutely is a role for childcare providers. They believe you. They know that you're trying to keep their child safe and healthy. So anything you can do to lend your voice. We've already seen 30% more people in Michigan get a flu vaccine this year. We're on a really good track, but any help you can offer us there would be so appreciated.
Yeah, good point. We all need to be drumming the flu vaccine bandwagon, so to speak. So I'm wondering, now that we've had some experience with young children wearing masks, given that that is such a key thing that we can all be doing, helping young children as well as wearing masks ourselves, of course, if there are any best practices that have emerged. Erika, at Lara, have you been hearing from childcare providers how that's working for them and how they're making it work in the best way possible?
I will tell you, Lynette, wearing masks it's new to all of us. Well, it has been new, and I think that we're all getting a little bit more used to it, and we're getting more used to seeing each other with masks on. I'm sure that now that we're 8 months into the pandemic, we've started to learn what is working for us and what's not working. I think child providers are also learning that also. Talking to providers in my region, I know that there were some that were nervous about whether the young children are going to be able to wear masks and how they're going to handle their masks. I will tell you that in talking to them, they did find some practices that were helpful for them in helping the children to become more accustomed to it. Some of them would find masks that had characters on the mask, so the children were excited to wear the mask because it may have a special character that they were like one of their favorite characters. So children were excited to wear that kind of mask. Some of them had smaller masks that they could put on stuffed animals or dolls, and so children were able to not only wear their mask but also put masks on stuffed animals or dolls. So again, it helped them become more accustomed to the masks. There are different sources out there for providers to use if they're looking for more ideas of how to help children become accustomed and comfortable with masks. I know the American Academy of Pediatrics and Mayo Clinic have different tips on their websites to help give ideas for wearing masks. The governor and MDHHS, Michigan Department of Health and Human Services, did issue a mask requirement for children and staff in childcare settings. And I think everyone is aware of it, but just in case there's any questions, those are detailed in our guidelines at michigan.gov/childcare. And we'll put that link on our chat. I want licensees to know that our consultants know that children aren't perfect and that children may give some hassles or kickback to wearing masks. When our consultants come out in the field, our consultants are gonna be wearing their face masks, and they're gonna expect everyone that's required to wear a face mask also. So I want providers to know that. And if a provider had an issue with a child wearing a mask, talk to your consultant about it. And I do want to say that I'm grateful that Lara partnered earlier this year with Zero to Thrive to discuss these questions. We know children are resilient, and children over the age of 2 can wear masks, and it can be successful.
Yeah, and I would just add to that, really from a developmental standpoint, we feel that children over the age of 2 are capable of doing this. And as Erika mentioned, the link to the AAP that's in the guidelines, I think is helpful. We often with our families use the example of, anyone who's a parent and has had a young toddler knows that there is a phase they go through where they really would prefer not to wear clothes. And we, as parents, have to set the expectation, model the behavior, and practice wearing clothes. And ultimately, we send them out into the world clothed. So, you really can use the same example with the mask. It takes practice, it takes modeling, but it also takes expectation. But most kids are capable of learning to wear a mask.
Mhm.
In our clinics, in pediatric clinics, what we've been trying to do is make sure that the parents role model for their children. So we encourage the parents to make sure that they wear their masks correctly, and then make it a game with the kids. Try as much as possible to make it fun. Every time they put the masks in a correct way, we give them positive feedback and encourage them to do that again. I think one of the nicest things is that we're seeing so many types of masks, different colors, little shapes, unicorns. We always make sure that we point out how wonderful they look and encourage our kids as much as possible to wear them at the youngest age possible. I mean, I've seen kids actually wearing it at age 1.5. It's just the parents want to role model for their children and at the same time teach them how to use it. Doesn't mean that they're using it correctly, but at least they're putting something, trying to put it in front of their face, and then they take it off. But they're teaching them at the youngest age possible. It is doable. But I have to say, at least in our clinics, we ensure that the kids at age 5 come in with their masks, and we encourage kids age 2 and above to wear their masks. That's our goal.
Great. Thank you, Dr. Mohammed. And thank you for joining us. I know you were actually seeing children this morning in the clinic, so we appreciate you rushing to us and joining us. I'm wondering, in fact, if you might want to comment a bit on the new screening protocols that childcare and early education settings should now be implementing, given that it's flu season, as well as quite a lot, as we've already discussed, and I think everybody is aware of COVID circulating out there.
Yes, from the guidelines, universal screening is recommended, but it's not required for children. If you're not conducting the screening on site, it's recommended that families screen for symptoms before coming to the childcare. Providers in clinic are required to screen, and all employees, at least at my clinic, they have an app. We call it the Responsi Blue. And you have to fill it in. You have to check in with a main staff member to make sure that you have all the information on your screen accurate, screening negative. If you don't have that app, they give you a piece of paper, but you can't move from that point until you make sure that you've been screened. So that's really how it's happening at hospitals and health centers, is that every staff member, every provider gets screened before they get in contact with any patients, even staff members. So I'm very, very pleased that screening technique is easy, because in the beginning it was very difficult. We couldn't find what to do and how to do it, but now it's been universally applied and it's become very easy to do. We got used to it as well. I encourage anyone who's in contact with any other people to do it. It's safe, it keeps you safe, and then you can make sure that the person who's sick or not feeling well that day is not going to be in contact with other people.
Lynette, I dropped a link in the chat because the state of Michigan does have an app that's available for free for employers to use, the My Symptom tool, that is doing exactly what Dr. Mohammed just talked about. So as an employer, that would be a really excellent tool to check out, in the links in the chat box.
Yeah, perfect. Thank you. I did see that pop up, Michelle. Great. Dr. Swindell, did you want to add anything to the notion, the thought about?
Well, yeah, I think, and we'll get into this, I think, in a little more detail, but there is still no clear consensus over what the best way to screen is. And they're all about symptoms that could possibly be symptoms of COVID. So when you look at the state app, which is what University of Michigan, Michigan Medicine uses as well, it divides them into higher risk symptoms and symptoms where you would have to have 2 symptoms in order to be excluded. If you look at the American Academy of Pediatrics recommendations, they have a slightly more conservative approach, which is using a list of symptoms that reflects the CDC symptoms. And if you have any of those symptoms, you're recommended to basically stay home and call your physician. And that will include symptoms like runny nose, which I know we'll be talking about quite a bit, and I know is on everyone's mind. So I just wanted to put out there that there are going to be different approaches to symptom management that could be reflected in each individual provider's own illness policy. And many pediatricians may recommend a more conservative approach.
Perfect, thank you. One thing that I wonder, Dr. Mohammed or Dr. Swindell, that we're seeing some comments about in the chat is just the issue of how to respond to parents that say it is not healthy for a child to have a mask on all day.
I'll take that. So I look at it from the perspective of, this was actually one of my staff members said it yesterday. I don't think anymore of symptoms. I don't think anymore of how much you can isolate. I think of how many lives I can save. So every step that we take it as we can do it. It's a skill, and mask wearing for kids is a skill. And I think role modeling for the children that you have in the daycare is very important. They may not have the role model at home. You never know that. But you can try as much as possible to have the kids use that mask. There is maybe a bright spot there, is that the transmission of the illness in kids, at least, seems to be less, at least based on evidence. We're not going to talk about high school and colleges, but in younger children. I don't know if that's enough to make people feel better, but as much as possible, try and implement the whole, washing hands, keeping hygiene, maintain distance, and wearing masks, because those are the tools that we have. And you have to try as much as possible to teach the children to use the right utensils, to eat their vegetables. This is another skill to try and teach them as much as you can. I hope that helps.
And in all of this, we're going to be using our best judgment. Maybe on a day like today, when children are outside and have the ability to be spread out more, not in an enclosed space, maybe that's a time for a mask break if it seems like it's needed. But honestly, children are in school all day long, all around the world with masks on, and I am not aware of evidence that has said it's harmful to them.
Right. Yes. Yes, thank you. And somebody in the chat said that they use the analogy of seat belts, and this person and I must be roughly the same age, that, you know, seat belts became much more popular during my childhood, didn't become mandatory until I think I was into early adulthood anyhow. And, you know, we wouldn't, you know, when I remember being a little kid and getting in a car and not being seat belted. In fact, was in an accident once where I went flying because of no seat belt. And, you know, now we wouldn't think of getting in a car, the adults not having their seat belt on, let alone the children, right? So that it's a similar sort of thing. We just have to, and I think there are still people out there that maybe occasionally claim you're safer without a seat belt on. Well, in fact, no, you're not. And certainly masks are the safest bet currently. Okay, so let's take on these symptoms. I know many of you have already mentioned in the chat or have even emailed us questions about symptoms, particularly those sort of difficult to differentiate runny noses. So Dr. Swindell and Dr. Mohammed, how is there a way to differentiate COVID and flu symptoms for a starting place for this conversation?
Well, the short answer is no. These symptoms for influenza and COVID overlap. And I want to, as we start the discussion about this a little more, I just wanted to clarify that when we talk about the flu, it's often used interchangeably with lots of kinds of illnesses. So, for example, we often talk about the stomach flu. For the purposes of this conversation, we are using the term flu for influenza. This is a serious group of respiratory viruses, and every year, many children in the United States get very seriously ill from influenza. Last flu season, almost 200 children in the United States died from influenza. So this is what we're talking about with influenza. The symptoms of influenza and COVID really overlap to a great degree, and there's been no single symptom of influenza that you would never see in COVID. So, you know, I think one of the points we really want to make is that, boy, we respect and depend on childcare providers so much. You have such an important role in the healthy care and development of children. One thing you should not have to feel responsible for is diagnosing illness in these children. That's our job. So please, if you have a child that has symptoms of illness, we would like to take that responsibility off your plate and put it on ours to decide whether that child is safe and able to be in childcare.
I'll just add to Dr. Swindell. When a parent contacts our office and says, my child has nose congestion or a runny nose, and we're not even in the flu season yet, our concern is always, oh, okay, well, this could be COVID. Hey, let's start looking into this. And then we have a whole list of steps that we take to try and assess whether this child may have been exposed, for example, to COVID, whether the child can stay at home for COVID. And we start talking about quarantine and isolation. I don't know if those two terms have been brought up, but the CDC actually differentiates between quarantine and isolation quite well. Just to let you know that if there is a child who has nose congestion, the first thing we ask is, have they been exposed to anyone with COVID? And that's exactly the same as the screening questionnaires that you may have if someone has symptoms. So quarantine means that someone who was in close contact with someone who has COVID-19 has to be quarantined away from others. Now there's something called isolation This is someone who is sick and has been tested positive for COVID-19 without symptoms away from others, even in their own home. So you have to consider there's a bit of a difference in those two terms. I just wanted to clarify those. But if a child, for example, has symptoms and they're not sure if they have been, they've been exposed, we ask them to stay home and not to be in contact with other people until they can get some more clarification of whether they've been exposed or not, or they test. They have to stay a certain number of days at home. So if you have had a positive COVID test, you're supposed to stay away from other people for at least 10 days, 24 hours of having no fever. That's a very important point. And the symptoms have improved. Now, if you have to quarantine, that's a bit different. You don't have the test, you've just been exposed. You have to stay away from other people for at least 14 days from the last time that you have been exposed to a person who had a positive test of COVID. Now, let's say we're in the mid-December period and I get a phone call from a parent, and now we are having some symptoms of maybe fever or cough and congestion. My little wheel goes, okay, now we have to start thinking of influenza. And we are at any point of time expecting our first flu case. Right now, we're keeping a very close eye from the health department, waiting to see if they are going to send us anytime a message, hey, we have our first flu case in our area. So at that point of time, we have to consider, okay, we may have to test for flu. We call it epidemiological testing, to see if it has come close enough to our area. And if we have a few cases where it's positive, then we have to consider that, okay, now we have to deal with the two viruses, and we have to start looking into the symptoms. Remember, in influenza, we have a vaccine. So that's the difference. If you have influenza and you are starting to feel better, maybe the doctor has given you a medication that shortens your symptoms, and children can have that medication as well. You're not having a fever for 24 hours, you are able to go back. The reason is, the assumption is that everybody is vaccinated with their influenza vaccine. They've all received their flu shot. So this is not the case in COVID. So this year is a unique year for a medical provider. When we test for someone who has maybe a fever or congestion, we have to test for both. I hope that helps clarify how we think in the process of medical care when someone comes in with either COVID or flu-like symptoms. It's going to be very difficult to differentiate, so we will probably start testing for both at a certain point when we start seeing it in Michigan. I hope that information helps.
Yeah, and I think, so just to be clear, a runny nose can be a symptom of both influenza and COVID. From the state perspective and the child care guidelines, runny nose alone is not a symptom that would require a child to be excluded from care. However, if the child's been well and develops a runny nose, I would say from the pediatrician perspective, we would prefer that that family calls the doctor's office. There's lots of things that can cause a runny nose, of course, beyond these two things, and almost always it's going to be one of those other things: a common cold, allergies, sinus infection, a Lego that got stuck up one nostril. It's happened many times. But we also know the child's history, and we will ask that exposure history. So from our perspective, even a runny nose, we would recommend the family at least touch base with the doctor's office. I think in many, many cases, that child will be cleared to go back to childcare with that runny nose, because we know that the vast majority of runny noses will not be COVID or influenza. But this is a different winter, and a more conservative approach makes a lot of sense in an area with high community transmission of a pandemic virus.
And we have to keep reminding ourselves that we're doing this for the safety of the staff, the children, right? And that's why we think of it from a conservative fashion. It's like, okay, let's look into it. Let the doctor take the responsibility. Thanks.
And I'll take this opportunity to just clear up one thing, which is teething. It's a common, common perception, and believe me, I've been there with my own teething children many years ago, that is one of the reasons children get a runny nose. It's not. So fever and runny nose are not a cause from teething. Again, we can provide some links to healthychildren.org. Has a nice section on teething and some of the symptoms you might see with teething or often see with teething. Lots of drooling, sore gums, chewing, but not fever, and particularly not fever of the kind we're concerned about, that 100.4 or above, and not runny nose. So let's take teething out of the mix when we're trying to sort out the cause of a runny nose in a child.
Yeah, and just to clarify, a fever is 100.4 when someone calls us to office and the temperature is 100. Of course, there are we have to figure out, is it truly a fever? Was it checked the right way? In other words, the quality of the temperature taking is important, but let's say it's accurate. A temperature of 100 is not really called a fever, at least in a pediatric office. And can you have a little higher temperature when you're teething? Yeah, it's possible, but a fever is 100.4 or above. So if you have a fever, 100.4 or above, and you're maybe teething or it looks like teething, and you have a runny nose, those are all things that you have to, again, push to us, push to the medical provider, we'll deal with it. But if it's teething, no runny nose, no fever, that's a different thing. It's just teething. Thanks.
Well, thank you for all of that. I think we all just learned quite a bit. I do want to note, and perhaps Dr. Swindell or Dr. Mohammed, you can comment, lots of questions in the chat about testing and what do you recommend, a PCR versus the rapid tests? Lots of conversation out there in the media and other places about the rapid tests not being as accurate. So perhaps you could comment a bit on testing.
Yeah, I apologize. My cat is starting to meow again. So I'm going to tell you it's not my expertise. This would require probably an expert in our labs, an infectious disease doctor. But most of my information comes from the tests that I do. So to me, the most important is let's test. That would be step one. I don't think the childcare provider needs to worry about what test is needed. When I get the test result as a medical provider, I have to determine whether it's safe or not for the child to return back. So I hope that you don't need to worry about the type of tests. Right now, we have so many types of tests. I think we just came up as well with the salivary test, the test that you can do the saliva with in some areas in Michigan. But the piece that's most important is let us deal with whether the test was good, whether the test result was accurate, because there are different sensitivities and specificities. The other component is resources. There are some areas that you just cannot get like a point of care test that comes back in 5-10 minutes. Other places, that's the only one that they have. So there are many factors that I don't think you need to worry about, except when you get the test, is it considered to be positive or negative? And does the medical provider clear the child to come back and return to the daycare center? Just to make it easy for you guys, I apologize.
And I have many of the same questions that you all do. I'm reading the same probably articles or seeing it in the news. So I think for the rapid tests, and some of them are being billed as things you would be able to get at the pharmacy and do at home, the answer is we don't know yet how those are going to be used, how we recommend to use them, and whether they can be used accurately in children. And then, you know, the questions again of how good a test is it? Right now, we still use the PCR test as our best test to tell you whether there is evidence of virus in the body at the time the test was done. And so that is still what we're using as our standard test.
Thank you. So many issues to think about with all of this. So Dr. Swindell, if we can keep you talking to us maybe a little more about symptoms and what, or if you would recommend the child care providers post a list of symptoms that would prevent a child from being able to participate in child care or in an early education setting.
Yeah, I think that's a great idea. I think, you know, obviously each child care provider is going to have their own illness policy, but as it with everything, the more transparent you are about it, the more the rules are stated clearly, and the policy is reiterated and followed, the less surprise there will be. And I think a couple things. One is, again, going back to that main point of where we started, we're doing this to prevent illness and save lives in the big picture. It is inconvenient and we are all stressed, but this is the reason why illness policies might be a little more restrictive this winter if you choose to have it so. The other thing I would recommend is, for example, if you used the American Academy of Pediatrics checklist, put it on the pediatricians. Say, listen, you know, this is the recommendation from the preeminent pediatric organization in the United States. That's the recommendation I'm following. Don't deflect the frustration onto us. And you know, not onto your own decision making, because I really think you have to think about the safety of your staff, and I don't know the composition of children who may be at higher risk in your setting, but I think that's where each provider's illness policy has to reflect what they are the most comfortable with.
Yeah, I think that's outstanding advice, and I would echo, right? Put it on the state too. So I included in the chat a link to a poster that the CDC has created that fully aligns with the guidance that Laura has issued around which symptoms should exclude children from care for risk of COVID-19. And so I think some of you have raised the question of what can I put on my front door? What can I put in my parents' mailboxes or hand out to families to set expectations? That's a great resource to be able to use. I think some of you probably saw my little guy pop in earlier. I'm a parent myself. I'm a parent who wants their baby in childcare, and I'm sure it's pushed providers like you when they're, you know, borderline sick or not. Like, I'm sure all parents have. I think having that conversation before children are sick and saying, we all need a backup plan this year. And if your individual child is ill with any of these symptoms or any of the symptoms in your illness policy, we're going to be vigilant this year and we need your help and partnership. What's your backup plan? How can I support you in creating one? I think that's easier to have that conversation as opposed to that morning up when you're screening a child and you need to send them home. We'd hope that parents are conducting that screening in their own homes and that they're not bringing their children to care when they have any of those symptoms. I know the challenges with that, but that conversation early and often and sharing some of those materials can be helpful too.
So a little bit of a thorny issue has been brought up in the chat by a handful of folks saying that Some of the pediatrician offices around the state are not clearly communicating to families how long either a positive child has to quarantine and or isolate, or if there's another member of the family that's positive. So do either Dr. Swindell or Mohammed have some suggestions for where they might, the childcare providers, find some good information? Because of course then they are finding themselves in the position of having to make a decision to protect the rest of the children as well as their staff at their facility when the parents call and say, I wasn't given a clear guideline.
I definitely, the local health department. Really, those are where we go to ask our questions about contact, isolation, and quarantine. And we look at them as the experts in the spread of disease and the rules around that. And I agree, pediatricians are very busy day to day, and as much as we try to make sure that we're all on the same page with the same information, it can be overwhelming at times. And so really your local health department, I think, is your go-to place for questions about isolation and quarantine.
And I'll add to that, if you have an opportunity to research yourself, like you have time to do that, you're interested, the CDC has all kinds of resources for that. They have different types of posters too. One of the things I want to let everyone know from a pediatric medical provider standpoint is that the rules are changing constantly. Like every so many days, there's some additional fine-tuning that happens to the policies, the different types of contacts, quarantines, how many days you have to stay at home, what test is positive or negative. You can't catch up if you're seeing patients at the same time. So another resource, I'm wondering, Dr. Swindell, if there's a good relationship that you have with your medical providers in your area, maybe they can be referred to the website of the Michigan American Academy of Pediatric chapter, and then the CDC. But to tell you the truth, most of what I do, I depend on the health department. So whatever the health department brings up, whatever the health department emails, I usually go with it. And then if I don't find the answer, I go to the CDC. And I'm hoping all my colleagues are doing the same thing. And if not, you can guide them if you have a good relationship with them, or you just go back to the health department, which is what I usually do. So I hope that helps.
I just want to add one thing about local health departments. So I connect with our local health departments pretty regularly. And I know that childcare providers and our schools are top priorities for health departments. They want to return your calls as quickly as possible. As you can imagine, they have many, many, many calls to return. And so I know that their response time to you is not as fast as any of us or they would like it to be. So any patients that you can offer, and I think Dr. Mohammed said, right, we all need to have more information about public health than we ever thought we would need to. And so I saw a couple of resources in the chat for local health departments who have public information officers, and they have their own posters in your region to say, here's what quarantine means, here's what isolation means. They will be back in touch with you, but some of those resources can help you answer tough questions, particularly if you have a positive case in your site, in your facility, and you're trying to make hard decisions. They're there to support you, but I know our partners in our licensing division have also, they're learning shoulder to shoulder with you, but they can be listening ears as you're trying to navigate some of those difficult decisions about closure and requiring parents to find other care arrangements.
Thank you. Good advice, Michelle. Okay, so what do we do? How do we think about children with a chronic runny nose? What are our thoughts about that?
Well, you know, we'll say it again. This winter is different from previous winters in light of the pandemic. And so from my perspective, a child should be evaluated and cleared for daycare with the onset of a runny nose. A chronic runny nose, meaning it persists, again, can be a number of things. It can be a common cold that gets complicated by a bacteria. We call it a sinus infection and a need for antibiotics. It can be allergies. It can be a recurrent cold. But, you know, I think the key is for the initial onset of new symptoms, it seems to make sense to me that you're in touch with your doctor. If those symptoms then are stable and the child's not changing or developing new symptoms or new signs of illness, that's likely a child that will be in childcare with a runny nose. But we would err on the side of caution and have that child checked and cleared first.
Yeah, we may not be able to give you every case scenario during the session, but I would also err and be very cautious. If you are not comfortable, your baby, child, toddler is just snotty all over, this is something that you had noticed a week ago, it's not going away, that's probably not COVID. But let me put it this way. Today, you're not comfortable because, you know, some news network said COVID surged by so much in your area. Then you go like, I'm not comfortable. Can you please have the child be seen by their medical provider and rule it out? That's what we're here for. So again, never feel uncomfortable saying that I want to make sure that my staff are safe. I want to make sure the other children are safe. I will be able to save lives that way. So if you're at a point where you're not comfortable with it, it's not new, but you're just seeing more of it. You're not satisfied with just saying that it's a chronic like nose congestion that this child has had for the last month. It's the same. Please have the medical provider involved. We're very happy to see that child and rule COVID out if needed.
I always think about how well situated our childcare providers are to make these decisions, because you're making these decisions every single winter. And frankly, every season of every year, trying to decide when is a child sick enough to be sent home. For that individual family, that decision's always high stakes. A family member has to come pick them up, they have to leave work. Now it feels even more high stakes than normal. And I think your discomfort is a sign that this feels riskier than it is in a normal year. And I think that's absolutely true. That CDC poster that we shared, the guidance that Laura has 5 symptoms that you should send children home for, period. These other gray areas, I think your experience with these children is so important to bring to the conversation, and leaning on your medical professionals in your community, whether it's urgent care or a primary care doctor, such a critical part. They're on your team and they're on the family's team to try to make sure that that individual child is healthy, but that we can also keep your staff healthy and the community healthy. So I just wanted to cheer you all along a little bit, because I do think we're stretching muscles that you have. And like I said, a little higher stakes this year, there's no doubt about that. But I'm really excited that we have a team like all of you to help us do this locally.
Yes, can't underscore enough. All of you are doing amazing work every day, and you are very much appreciated. And I do want to take this moment to say, please take good care of yourselves, because you can't do the great work you're doing if you become ill, your staff becomes ill. And I mean take care of yourself in the broadest sense of that, taking time out for self-care, social, your emotional state, as well as your physical health. So many important issues. We got time for a few more. We could, I think, go on for quite a bit this afternoon, but many of you, I suspect, have children waking up from naps that you're going to have to start jumping off to start caring for those children. But we'll try to get to a few more important topics here. One that I think we would be remiss not talking about is the whole issue of talking to parents, especially, you know, these are difficult conversations often to have, as Michelle just said. We all recognize that all of this is disrupting parents' lives and their ability to get their work done. And for some families, it's an economic issue, right? They work a job that they don't have paid time off to be home with an ill child. So these can be very difficult conversations to have. But Dr. Swindell and Dr. Mohammed, I suspect you've had many conversations that were difficult with parents. And how would you suggest folks approach these conversations when, in fact, we know the parents maybe are pushing back and just want that child with the list of symptoms we've just been talking about to remain in childcare?
Let me take this one. So we kind of have the same model there in clinical practices. Yeah, you're right. Absolutely, Lynette. It's probably not just that one pressure that the childcare provider is going to put on the family when they say you need to pick your child up or you need to make sure that they go back home and isolate, call your doctor. There's so many other pressures coming from every way for our families these days. Financial, people who are sick in their own families that they have to take care of. And I specifically, I don't know if my experience can help, but I specifically work with an underserved population. And one of the things that we plan at all times is to provide tools for needs. It could be to find where the best dentist is for kids who may take their insurance. It may be that they need food that day, so we know what pantries are available in the area. We have some information about where supplies for clothing are that day, where they can get diapers if they need. So I'm wondering if the child care centers, or if there's maybe another website that you can go to where it will provide you with resources for your families as you sit down and listen to them. Naturally, in the beginning, as they are very upset and angry with you, you'll be listening. And as you listen, you pick up. You're probably the experts on that. You pick up, oh, there are other things happening in the family. I wonder if I can help them. And then be able to know what resources you have in your community to help them with. That would be my approach for all these pressures. And sometimes you may not be able to be the person to help them, but you call them the next day, double check and see how they're doing, and ask them if there was anything else that you could offer other than making sure that they stay safe and if they've connected with a medical provider. I hope that helps.
And yeah, I would just add, you know, we want to know if there is a family that seems particularly stressed. You spend so much more time with the children that see us and their families than we ever will. And we know how harmful a stressful environment can be on a child. And so if you're seeing red flags in a family that you haven't seen before, please also consider that as a reason to check in with the pediatrician, because we want to check in on the family. We have resources in our office too, social work, mental health resources that will help the whole family in these times of particularly high stress. And we are seeing increased rates of anxiety and depression without a doubt in parents, in teens, and it's manifested in different ways in younger children. So you are kind of our contact with families that may need to be seen for things beyond the runny nose. And we really appreciate what you do in that regard.
So another question that a number of folks have asked via the chat with regards to, we're sending, calling about one child, but we also have their sibling in our center. And if there's, any, particularly concern about COVID, which obviously we've learned today that all of these symptoms require us being concerned about COVID, what if the parent doesn't want to take that other child too? Should the child care providers be sort of making that part of their protocol, or what would you recommend in that case?
Let me take this one. Let's say, I'm just going to put it theoretically. Let's say the child who had the congestion and the fever turned out to be COVID positive. Then you go, oh, okay, the sibling, I wonder if they were asymptomatic carriers. So you may have to consider that both of them get picked up at the same time. You can take the risk and wait until the next day, but the end result is that if the test of the child who has the symptoms, the one that you decided to, let the parent pick up and take home, is positive, then you have taken those 24 hours of risk for other children and other staff members. I think that from my perspective, have both children isolate, make sure are quarantine. That would be to check and make sure that they are safe first, and then question mark on it, let the medical provider make the decision. Negative, then they can both come back. One of them or both of them are positive, then you have to make the decision at that point of time to isolate them for the period of time of 10 days without fever and symptoms.
Thank you. And I think we'll wrap up in these last couple of minutes with, again, being raised in the chat. A number of families are telling their child care providers they are traveling for Thanksgiving, even getting on airplanes. They are going to be at the Thanksgiving table with many members of their family. Should those families be asked to self-quarantine for a bit next week?
So you're screening them when they come in. And if there was exposure to COVID, then they have to go home. So it's part of your screening that you have been exposed to COVID. That would be your point. If the child has symptoms, that would be your point to make a decision that they have to go home. I hope that helps too. We don't know if they have been exposed, but we hope that the parents are honest. We hope that the parents tell you as soon as possible. If they screen negative, then they can return back to daycare. We are also not very happy, of course, that everybody is going back to meet their family. The CDC just came out yesterday, talk about how things are changing every day. CDC is discouraging travel and gatherings, but we understand the social stress of the families, and we understand that people want to be with their families. It's just going to be another reason for another surge, or at least another reason for a continuous surge over a longer period of time than we had in the spring. We're predicting that. We're also predicting that the flu is going to be there, but I mean, we just cross our fingers and hope for the best.
Well, we are out of time. Lots of conversation and comments in the chat of appreciation for all the information that our panelists have shared. So we do wish you all a very happy Thanksgiving. We will send out an email that has all the different, there were lots of links posted in the chat and to great information and even materials. So we'll make sure that goes out early next week in an email to all the participants. All right, thank you all so very much. We appreciate you spending this time with us. And again, happy Thanksgiving to all, and please be safe.